For 50 years, Medicare has been the healthcare safety net for America's seniors. But with the flood of retiring baby boomers, the question is, will Medicare be there for you when you reach 65? Find out in A Boomer's Guide to Medicare. Funding for the Best Times is provided by the Plow Foundation, striving to do the greatest good by helping the greatest number of people since 1964. Additional funding is provided by the members of WKNO. Thank you. Hello, I'm Chris Hardaway. Welcome to this edition of The Best Times, a series that looks at life after 50. I've got a milestone birthday coming up, and I've received an extraordinary amount of birthday wishes, all of them from people I don't know. You see, I'm turning 65, and these birthday cards are from insurance companies trying to sell me Medicare Advantage plans. Here's a question. Do you know what a Medicare Advantage plan is? If you're turning 65, you should. Here's your opportunity to find out in A Boomer's Guide to Medicare. "50 years ago, on July 30th, 1965, President Lyndon Johnson signed the bill creating the Medicare program. The passage of the bill was the culmination of nearly 50 years of discussion and debate on national health insurance. President Johnson presented the first Medicare card to former President Harry Truman in recognition of his efforts to establish the Medicare program. In 1965, less than half of Americans over 65 had any form of health insurance. Today, almost all seniors, that's nearly 55 million Americans, are covered by Medicare. Now that you know some of the history of Medicare, it's time for a quiz. Here's your first question. How much will Medicare pay out in benefits this year? Is it A, $289 billion, B, $585 billion, or C, more than $800 billion? The correct answer is B, $585 billion. Medicare represents 14% of the total federal budget. Try this one. When can you apply for Medicare coverage? A, at age 65, B, 3 months before you turn 65, C, 3 months after you turn 65, or D, at age 66. The answer is B. There is a window of 7 months around your birthday, 3 months before and 4 months after, during which you can enroll. If you're already receiving Social Security, the government will send you a reminder. If you're not, you'll have to remember to enroll on your own. Here's our last question. Medicare is projected to remain financially solvent until what year? Is it A, 2022, B, 2030, C, 2044, or D, next year? The correct answer is B, 2030. By that year, almost 80 million Americans will be eligible for Medicare. Now it's time to examine the ABCs and Ds of Medicare. There are 4 parts to the system, and we begin with Part A.
Part A is for people who are hospitalized. It covers hospitalization. And it would cover skilled nursing if someone were to go into rehab. It would be that part that would allow them so many days to get rehabilitation should they suffer something, some sort of surgery that needed rehab, or maybe a broken hip that would allow a certain amount of rehab.
So Part A covers hospitalization. The deductible is $1,260 for each hospital stay. Extended hospital care is subject to co-insurance payments. But if you've paid Medicare taxes for at least 10 years, Part A is free. Part B gets a little trickier.
Part B pays for all outpatient services. It pays for your doctor's visits, x-rays, labs. It pays for outpatient surgeries. It pays for any services that would be classified as outpatient. Counseling, all the sorts of services that would be x-rays, anything that would be covered as outpatient.
Most people will pay $104.90 in premiums for Part B. However, the premium does increase for incomes over $85,000. It allows you to choose any healthcare provider that accepts Medicare, but it only covers 80% of the bill. Many people buy supplemental policies to fill the 20% gap. Part B is optional. In 1997, Congress established Part C, which is even more complex.
Medicare Part C is what they call an Advantage plan. An Advantage plan is privatized Medicare. It's called Medicare Part C. Often people call me and they say they need Medicare A, B, C, and D. Well, it's not that they need Medicare A, B, C, and D, because C rolls Medicare A and B, which I just said was original Medicare, and it takes Medicare D and it puts them all in a unique bundle, which is privatized Medicare. And when you have the Medicare C product, it actually removes you from original Medicare and puts you into the privatized Medicare. So you no longer have Medicare in its original form anymore.
The advantages of Part C may be lower premiums and/or expanded coverage and benefits, such as eye exams, eyeglasses, and dental care. The downside is, as with any HMO-type program, you're limited to a specific list of healthcare providers. Should you choose an Advantage plan? Here's Vicki Thompson's advice.
Advantage plans are designed for people that are relatively healthy, that don't see doctors very often. Chronically ill patients who see a number of doctors in a month or maybe every 2 months, those plans are not really designed for chronically ill patients.
Part C plans vary by state and by county. In Shelby County, you can choose from 22 Medicare Advantage plans. The final piece of the Medicare puzzle is Part D.
Medicare Part D is your drug coverage, your prescription drug coverage. And there is a premium that goes along with that. Now, the one thing I would tell everybody is that prescription drug coverage with Medicare is driven by generic drugs. So the fewer brand names you take, the lower your premium is going to be, and the lower your cost is going to be overall.
Part D is optional and may be covered in a Part C plan. If not, you'll pay a monthly premium. There are 30 Part D plans to choose from in Shelby County. So, how much does it all cost? Vicki Thompson says a ballpark figure of around $300 per month is the average cost of the premiums for Part A, B, D, and a supplemental policy. Keep in mind the average Social Security check is less than $1,300 per month, so Medicare costs take a serious bite out of that check. 10,000 baby boomers a day are turning 65, and by 2030, 1 out of every 5 Americans will be eligible for Medicare. So the question is, will Medicare continue to be able to provide health care coverage for our most vulnerable citizens? To answer that and other questions, I spoke with 3 experts on health care. Dr. Teresa Waters is chair of preventive medicine at the University of Tennessee Health Science Center. Dr. Cyril Chang is professor of healthcare economics at the University of Memphis. And Dr. David Mervis is professor emeritus of the departments of preventive medicine and internal medicine at the University of Tennessee Health Science Center. Well, Medicare is about to enter its second half century, and I'm curious to know what all of you feel. What would you rate Medicare? What grade would you give it during its first 50 years? How has Medicare performed?
I probably would say a B or B+.
Why?
I mean, it clearly has provided health insurance to 50 million people, many of whom would not have had it before. And the health implications of that are just incalculable. Didn't give it an A because it's still a work in progress. We've just in the last few years added prescription drug coverage. People with Medicare still have very large out-of-pocket expenses. 80% or something have an additional policy to cover that. So it's a very good foundation, but doesn't really provide totally comprehensive health insurance.
Let's hear the grades from this side of the table.
Yes, I'm an easier grader.
Oh, okay. Remind me to take your class.
All right. I'm an easier grader, and I would give it a B++. Yes, but that's the overall grade, B++. But if we break it down, then I would give Medicare a A for coverage, a B+ for service provided, and then a just regular B for administration.
And what are your grades?
So I think I would agree with the first two grades, but I actually think that Medicare is working very hard, harder than most payers, to address the challenges of administration, to be forward-thinking, to move away from fee-for-service, and to try to be more innovative in their administration. So I'd probably give them an A- at administration.
So overall, I see good grades for Medicare's first 50 years. Now, the government spent about $500 billion on Medicare alone last year. Now that's only about $100 billion less than what we spent on defense. So if we could put a value judgment on this, how important is Medicare to America's seniors today?
Critical.
Yeah, I would have to agree.
Yes, vitally important.
Yeah, I mean, it's that floor on which health care for seniors is built. And on that floor is health.
Right. And I would say, to add to that, and I guess this brings my economist backing to that, is that it's also financial stability. So it's not just access to health care, which of course is really important, but the fact that you can retire and not worry about losing all your retirement savings and your ability to enjoy those, 20 plus years of retirement.
I have to agree that the two best things that have happened to American seniors in the past 60 years have been Social Security and Medicare. Without them, the quality of life of American seniors would have been much lower.
And they're related. Because you can't, you can't just have Social Security and not be able to cover those those catastrophic illnesses, which are much more likely when you're over 65.
And yet both programs are oft maligned by people.
Well, they're expensive.
There you go. They're expensive. The $500 billion, which of course is going to continue to go up as we look toward the future. And that's one of the issues that maybe we should go on and get into now. You've got 10,000 baby boomers a day, roughly, that are reaching age 65, becoming eligible for Medicare. What is going to be the impact of the boomer generation on Medicare?
Cost and benefit. You're going to have more people getting benefits from it at a cost. And then it becomes, I guess, a political value judgment. Is the cost worth the benefit? And I think to me, Medicare will be here. It will look differently. All health care will look differently. So a lot of the changes that are going to impact Medicare reflect changes in the overall healthcare world. Regular insurance prices are going up, costs are going up. Issues of access and changing of systems apply in the private insurance world, and they're going to affect the same way. A lot of things in Medicare are not public policy changes, they're commercial market changes impacting people with Medicare. Rising costs of gap insurance is a commercial market issue more than it is a governmental policy issue. So it's a very complicated scenario.
The boomers are usually the cohort of American people born between 1946 and then the next 10 years. And they have been described as the bulge in the python. They move through the snake, and then you see the boat moving. And they have sort of created a lot of changes, pressures on the economy and American society, and it's something that we have to deal with. And now healthcare is no exception.
Well, what an interesting visual metaphor I have in my head right now. So right now we've got about 50 million Americans that are using Medicare. And then once all the boomers have reached 65, that number is going to come close to doubling, about 80 million. And this gets back to what you were talking about. How is the system going to be able to cope with that kind of dramatic increase?
Well, I think what we're going to see is what we've started to see already is issues of cost control. Most of the efforts are reducing cost one way or the other. Issues of changing healthcare delivery models is meant to impact both volume and unit cost. If we have more primary care, presumably we will have less chronic disease. So there's that approach. There's actual cost restriction, cutting fees, cutting payment rates, dealing with evidence-based practice to reduce unnecessary costs. All of these things are there. Now, will they be sufficient to meet that doubling of number of people without much more significant or even draconian cuts? I think is the question.
Yeah. I would add on to what David said and say that there has been a lot of activity at Medicare to try to not take unwise cuts, just cuts in fees, but to try to do things smarter as opposed to just, sort of blindly making cuts. So a lot of the terminology that is used is fee for value, pay for performance. So trying to say, can we measure the outcomes of what providers are bringing to the table, to the improved outcomes for our beneficiaries, and that's what we want to pay for. And so reorganizing the way that care is delivered to get more for less.
Again, the cost-benefit.
That's right. That's exactly right. And so there's a lot more activity in this realm, which is promising. Now, whether it's enough when you have so many more beneficiaries, that is a real question. We're just going to have a lot more people to take care of because we know that the end of that part of your life is when you have more medical needs. We're going to have more providers. I think we're just going to have to, at some level, we're going to have to deal with this issue that we are going to have to provide more care.
Well, and not only is there going to be an increase in the people who use Medicare, there's also a decrease in the number of people who are actually paying into the system, who are actually paying for it. So that too is going to have a huge impact.
Right. Now you have potentially 3 solutions. Well, number one, you reduce the services you provide, which is not popular. The second is that you increase the revenue to support the Medicare program, and where will you get the money to support Medicare? Through raising taxes and fees. And that is, again, very unpopular. And so now, what's left? And I think the third solution probably is where we're going to have to put our heads together and try to come up with smart solutions is to improve the efficiency, to raise the productivity of the delivery systems, and to begin reduce waste, unnecessary services, and to reduce errors made through the process. And that's where probably holds a lot of promises sort of to deal with the dilemma we face.
Are we heading in that direction to do that?
I think so.
I think we're heading in all 3 of those directions.
I was going to say, what David and I were talking about was more efficiency. Yeah. I agree, Cyril, that there's some room for squeezing efficiency, but efficiency is in the eye of the beholder. and a little bit. I agree it can be measured, but I think we're not going to be able to accommodate all the new boomers through efficiency gains. I just don't see that being the complete answer.
The problem with efficiency in healthcare is Mother Nature. There's a huge unknown factor in taking care of people.
Right.
It's hard to prescribe exactly what to do when for an individual patient.
That's right.
And you don't know what the result will be of doing absolutely the right thing. The result is not predetermined. So it's very hard. The efficiency issue becomes very complex. Now, there's some things which probably never should happen in healthcare. And I think that's where Medicare has already made advances in saying we're not paying for things that shouldn't happen.
Even that's not quite as straightforward as they would like it to be.
No, it's not. But I mean, clearly there's some things that are beyond the pale.
Right. You should not cut off the wrong leg.
Exactly. Which surprisingly happens. And there's things that should happen so infrequently that you can almost say never. Or you can say never without a lot of harm. So those things happen. There are issues of physician practices, of unnecessary care, things which by professional standards, professional organizations will say don't do. But yet they're done. So how do you deal with that? So there's lots of room in that efficiency bubble to make advances, but it's not easy.
In 15 years, of course, 1 out of every 5 Americans is going to be over 65, eligible for Medicare. Oddly enough, Medicare will be 65 in 2030. Irony of ironies. What will Medicare look like at that point? What do you think it will be? Will it still be here? Will we have Medicare?
Well, I definitely hope so, since that will be the day I turn 65 as well. So I think it will be, because one, it's too popular, it's too important. And so a version of Medicare will be here. But I think, just as it's been changing over time, it will continue to change. So we might see something like we're seeing with Social Security, where the eligibility age changes. I could see that, where I won't be eligible for a few more years. Or we might see some means testing. We might see some income testing, where you have certain benefits at certain income levels. You know, right now there is absolutely no means testing, and that's been very unpopular. But you may have higher copays if you have a certain.
So in your view, accommodations will be made.
In my opinion, there will be some accommodations, and they may make Medicare look a bit more like what we see on the commercial side.
Dr. Chang, what do you think?
Yes, I agree. I agree with what Teresa just said. That Medicare probably will follow the example of Social Security, and so that with each given years that the eligibility years will go higher, and that's reasonable because American people are living much longer. And with longevity, you have more years to have your health care taken care of. As to the future, it's very difficult to predict what Medicare will look like, say, 30 years from now. But I think in all likelihood that Medicare will be there for future generations because it's just so important. And so in some form or another that it will be there. In fact, I'd like to quote a quote that I heard not long ago, that the demise of Medicare is premature. It won't happen.
Do you agree that the demise is premature?
Yeah, I think at 65, Medicare will be on Medicare.
It will be.
And it will be there for Medicare to be on. I think we're going to see lots of changes. We've already seen some form of means testing. The payroll tax goes up for higher income people now. The way Part B and Part C or D are constructed, fees have to match 25% of overall cost. So a lot of these changes, the financial changes, are already built into the system to happen.
That's true.
And just like in commercial insurance, more and more cost shifting to the patient. And this then feeds into the increasing role of gap coverage, which then falls into the commercial realm. So the interaction of the public insurance through Medicare and the commercial insurance for gap will become even more complex but important.
Well, I look forward to sharing a Medicare future with all of you. Thank you very much for being on The Best Times. Good discussion.
Good.
For more information, go to Medicare.gov, where you can download the informative Medicare and You Handbook and enroll in Medicare electronically. To get all your Medicare questions answered, contact the SHIP program at the Aging Commission. I'm Chris Hardaway. Join me next week for more stories about life after 50 on The Best Times. Funding for The Best Times is provided by the Plow Foundation, striving to do the greatest good by helping the greatest number of people since 1964. Additional funding is provided by the members of WKNO. Thank you.